Welcome to Knowledge on the Go, where we explore the leading practices that have emerged in Vizient's PI programs. I'm Jim Lichauer, Senior Performance Improvement Director at Vizient and the host of today's episode. The pharmacy revenue cycle is a multi-phase, continuous process which requires ongoing collaboration across many disciplines. The process starts at pre-registration and continues through payment reconciliation. Joining me today to discuss this process in greater detail is Stephen Loborec, Associate Director of Pharmacy at the Ohio State University Wexler Medical Center. Welcome, Stephen.
Thanks for having me on today.
The revenue cycle is quite complex. Can you provide a brief overview of the process in the areas you are engaged in?
You're absolutely right. The revenue cycle is complicated and it takes several teams of people. At OSU, we have multiple teams that collaborate regularly for a successful revenue cycle process. The areas that I'm involved in include our overall pharmacy revenue strategy, where we're really focused on what is the pharmacy's contribution to overall revenue, and also, probably even more importantly, the ultimate margin that it's able to generate for the system. We're incorporated in areas where we can work to optimize this revenue and even generate new streams of revenue. And this can also include various contracting initiatives. Other areas of the revenue cycle include the pre-access phase. And so many of our listeners are likely familiar with benefits verifications, prior authorization, and even working with our patient assistance teams. At OSU, we have an integrated electronic medical record system where the clinical care and the documentation that our teams do within that system ultimately lead to automated charge capture at the point of service and when drugs are administered to the patient. And then we have our mid-cycle, which is another area where I am highly involved, and that's in our charge master maintenance and overall strategy, in addition to our billing and coding, as well as waste billing. And then on the back end, once the claims are submitted to the payers, there's another phase that we call the post-access phase. And this is where you'll typically find your denials and your reimbursement reconciliation. To top it all off, there's performance metrics, where we look at and measure what's happening in each of these phases to help us better understand and make sure that we're meeting our goals.
So you mentioned the charge master. What opportunities have you identified in that area and how are you addressing them?
The charge master is one that's been a really interesting topic with a dynamic environment. First, there's been a lot of newer regulations in the charge master space. There's a call and need for charge transparency for hospitals and health systems to post online their charge master in a machine-readable format. The idea behind this is that it allows patients to compare standard charges across institutions. In order to prepare for that, systems need to be A, aware that this is happening, and B, ensure that their prices and charges are in alignment with the market. Nobody wants to be on the front page of the newspaper as a system that has obscene, ridiculously high charges that are perhaps unsubstantiated. So being aware of this regulation is incredibly important. Charge masters are becoming more and more transparent, and you want to make sure that they're accurate and appropriately maintained at regular intervals. Some things that we've done at OSU most recently, adjusting some of our charge masters to be based upon more national trends, such as basing charges off of wholesale acquisition costs, which is a really easy drug cost target to identify, and also making sure that the markups are in alignment with our peers. That way, the charges that are ultimately produced are appropriate.
So besides charge capture and charge optimization, you mentioned new revenue streams. How have you found additional revenue streams?
Yeah, this one is a really interesting opportunity that, as I've come to learn, not every system is taking full advantage of. About a year and a half ago, the federal government changed some of its billing guidelines as it related to the billing of single-dose vials administered to patients in the outpatient setting. The issue with the single-dose vial is that by its label, you are only allowed to create one dose from the amount of product in the vial. However, there's often a lot of extra drug in the vial because the drug may be weight-based or have different doses based upon the indication, but the product is perhaps only supplied at certain intervals or sometimes even just one strength to purchase. In those situations, waste is created, and historically, that waste really was just waste and it had to be thrown out. The government has tried to acknowledge the fact that hospitals and health systems are essentially having to buy this drug, knowing full well they're going to have to throw part of it out. And as part of their passing of the Inflation Reduction Act, what they essentially are doing now is collecting data on the medical claims of what amount of drug is wasted that essentially the government is paying for. So the government has created a mechanism where you can put the JW modifier and bill for the waste that you were required to buy in order to treat that patient. And the government will essentially reimburse you for this waste that you are, from a regulatory perspective, required to discard. The good news is that from a cost standpoint, hospitals and health systems were already buying these drugs. Their cost really shouldn't be changing. But the new revenue stream is the opportunity to bill for this waste and create new revenue as a result of it. And the real opportunity is acknowledging that while the regulation exists only for Medicare, the opportunity exists in the commercial market. What we know about the revenue cycle and the billing arena is many commercial plans will often follow and default to the government billing regulation. As the JW modifier was created, the federal government agreed to pay for waste. We saw many commercial plans also paying for that waste. Maybe not in a officially announced and advertised way, but due to the fact that in their contracts and their payer policies, they reference the Medicare billing manual, and in that manual is what allows for waste billing by default. At our organization, we took an opportunity to say, if we could bill all payers for this waste and not just the government, we could create an opportunity for additional revenue. So by turning on this functionality, documenting the waste for every patient, billing it out on every single medical claim, we found that many commercial plans are actually paying for these waste claims. And it's at a point now where we're recognizing about $2 million a month in new revenue stream that we never had before. Another opportunity within this area is partnering with our revenue cycle team on this initiative. When I first introduced the idea of billing waste to every plan that OSU is working with, it was initially met with a bit of feelings of being overwhelmed and nervous about what that might do to the denials workflow on the post-access stage. We thought creatively and put our heads together to say, we believe that there is a large number of payers out there who will just pay these claims. We also believe there's payers out there who may deny it, ask questions, and create barriers to this new revenue stream. So we created a opportunistic model that billed everyone for the waste if it existed on that claim. But then if the payer were to shoot back a denial related to that specific waste bill, it was automatically written off, meaning that we did not expend any energy explaining it or doing research or having a manual review and work on that claim. We just said, no harm, no foul. We weren't getting paid for it yesterday. We'll continue not getting paid for it, but we know at some point we're going to get paid for it. And so I viewed that as a great compromise between both teams because I knew there was an opportunity for more revenue, but I also knew there was great hesitation for signing another team up for a boatload of new denials when we already have a pretty overwhelming amount of denials to work through on a regular basis.
So we talked about measuring and monitoring this and keeping track of it. How are you measuring performance? How are you identifying that you paid, but you got paid what you were supposed to get paid? And also identifying medications or sites of care where you may generate the greatest margin. Can you explain some of that and how you're identifying those opportunities?
In anything, the metrics and the data are where you should be living and dying by when it comes to the revenue cycle. If the data doesn't support it or you don't have access to the data, you're going to be limited in what you can do. So at OSU, we've created a few dashboards with a system that talks to our electronic medical record. It allows us to essentially look into all of our medical and pharmacy claims and identify the claim lines that are specific to waste billing, those with the JW modifier. And we can add up all of those charges across every claim. We can look at what's getting paid, what's not getting paid. And based upon the other attributes of the medical claim, we can see what insurance payer it is, which drug it is, which infusion location perhaps, or site of service it is. And we can create various dashboards and visuals to help inform and model that activity. Other things that we're also doing in the dashboard space are trying to mash up our purchasing data, because I think we all know pharmacy purchasing is incredibly complicated. There's not just one price your institution is buying a drug at. There's various class of trades that are able to access different contracted prices. Then there's various government pricing programs such as 340B. And then there's wholesale acquisition cost or just straight whack pricing. And so we often buy the same molecule, the same product at maybe 4 different prices. When you're working with a standard cost accounting data modeling team, they definitely struggle with that concept of the same item having perhaps 4 or 5 different values associated with it, and all of them actually being correct. What we've found is an opportunity to mash up by site, because oftentimes the acquisition cost variable aligns very nicely with the site of service. Is it a retail class of trade that has access to this contract? Is it a 340B child site that has access to 340B pricing? Is it an inpatient unit? Whatever those differences are, we can leverage our purchasing data to say what is the actual invoice cost of that product in that location, and then mash that up with the revenue and the insurance claims that are coming through specific to that location, where you can essentially net them together and say, what's the revenue coming in for this drug? What's the actual invoice cost of that drug in that location? And what's the margin that it's producing? Once you have all of that mapped together, you can essentially sort right from high to low and see what are the drugs, maybe by payer and by site, that are contributing most positively to our operating margins, and what are those that are either contributing in a small amount or perhaps negative contributions, which also happens. And in my conversations with some of my peers around the country, I've learned that most people do not have that level of insight into their data. If they did, they could start to make some enticing strategic decisions, specifically around access and facility structure. In our own system, we have some access issues where there are patients who need certain infusions, but we don't have enough infusion chairs and capacity to get them all in at the schedule they want to be in on. If you had that information alongside what is the greatest margin generator, what if you learned that your top margin producing drug has a wait list of 100 people who want it and they're leaving your system to go get it somewhere else? That is a missed opportunity that many of the people listening to this podcast may not even know about. The notion of that data should be driving the strategy and working with your teams to develop those tested and proven data models so you can use to inform the strategy moving forward.
Stephen, can you share some lessons learned for our listeners today going through this process?
First, you have to acknowledge that the revenue cycle is incredibly complex, and many of the pieces can take a lot of time and effort to change over time. And it can be overwhelming. Pick one piece of the revenue cycle that's a particular challenge for your organization and come up with a plan to make incremental improvements over time. Even at our own system, while we have come a long way in various areas, we still have opportunities to improve ourselves. And it's about taking it step by step, being persistent, and recognizing and celebrating the wins along the way.
Thanks, Stephen, for sharing your insights. That's all the time we have for this edition of Knowledge on the Go. And to everyone listening today, thank you for joining us. Please join us for more knowledge on the go. Subscribe today, like us, and send us your comments at picollaboratives@vizientinc.com. From Vizient's PI program team, I'm Jim Lichauer.